Dr. Rand back in Cali to see my good friend. We just had lunch. And we're back.
Trying to stay awake now?
Back to Ask the Doc. Some good questions from all over the world again this month. Very cool. Good to see you. Happy New Year.
Happy New Year to you too, sir.
It's good to see you.
Likewise.
Awesome. You look well. So what do we got, Doc?
Today we got a few questions. Looks like the first one starts off, I really need some help and not sure who to go to, ... I'm 19 years old and I'm having problems such as erectile dysfunction, depression, fatigue, low energy. I did one cycle of RAD 140 in July. I did it for only 3.5 weeks because I could feel the side effects hitting. In other words, gyno was appearing. And I was in the 4th week. I tapered off to 7 milligrams of RAD, but from weeks 1 through 3, I started off with 15 milligrams. I put on around 20 pounds in a month.
Wow.
After tapering off, I slowly got the effects of erectile dysfunction. After that, I got a random PCT from my local nutrition store that wasn't Clomid or Nolvadex. Took 6 pills a day and only took it for 2 weeks instead of 4. It was hard for me to get it up originally, but after the 2 weeks, I would really have to try to get it up, and it did. I'm assuming you're talking about erectile function.
Yeah.
But I feel like cutting it short at 2 weeks may have not been good because I feel like it disrupted my entire natural testosterone production. It is currently January, and I feel very low, and my erectile dysfunction is at a peak, and I have an extremely low sex drive and falling into a depression. Should I take Nolvadex, and if so, how much and for how long? I don't want to ruin my body any more than I already have and just want to feel normal again. I'm only 19. I think I'm about to get my blood drawn to see where my testosterone levels are compared to my estrogen levels. Any suggestions, tips, or recommendations would mean so much to me because I'm scared and I do not know what to do. Well, I wouldn't necessarily, what do they say? He who worries before is necessary worries more than is necessary. That was Seneca. And I wouldn't necessarily be scared, but let's figure this out. And I have to say, like we always say up front, I can't give you medical advice, so please don't take this as such. But I can give you some general information. You should definitely follow up with a doctor. I know we don't have a country here, but different specialties work differently in different countries. And here, believe it or not, an endocrinologist here in the United States is probably not your best bet when we're dealing with testosterone. I think in this country, the urologists, when it comes to dealing with testosterone for men, are really carrying the flag and will do so and probably be the guys to go to in the next decade. Thanks in large part to my friend Dr. Lipschultz and all his fellows that have come out of Baylor University, in the urology department that have learned from him and learned from a lot of studies they've done through Baylor University. And there's others, obviously, but I think that's the group, the urology group, that's going to take over, even though you say, well, hormones, isn't that endocrinology? I think I might have touched on this before, but, endocrinologists learn like we all learn. We learn in hospitals, and unfortunately, most of their training is what's learned through hospital admissions, and nobody gets wheeled in to the hospital with low T. It's usually diabetic ketoacidosis or thyroid storm. So they're really good with diabetes or thyroid, but not so much with testosterone. And I don't mean that to be indifferent toward endocrinologists. It just has to do with training.
Right.
But a guy like this has an erectile dysfunction problem. They're going to the urologist first because they think, okay, penis, urology, let's fix this. And so I think it's just evolved that way is all I'm trying to say. But I think that the issue here might be that at 19, before your hypothalamic pituitary adrenal axis has been, and we used to use the word hardwired, but we now know it's more softwired. But those connections haven't been fully matured yet. You introduce something like RAD 140 and you throw off the system. I call it crashing the boards. Most people recover, one way or the other. Most people recover. Every once in a while, someone, the boards crash and the wires never reconnect the way they're supposed to. And finasteride syndrome, I think, is probably one example of how that happens. I've gone on record of saying, finasteride syndrome, what does that mean? Because so many of the patients I've seen are in their 30s, let's say, or 40s, and they go on finasteride. Finasteride is a 5-alpha reductase inhibitor. They block the conversion from testosterone into dihydrotestosterone. They suffer from erectile dysfunction because a large group of males needs the dihydrotestosterone apparently for proper erectile function. And bodybuilders know that when they use nandrolone, decaduroblin, which creates dihydronandrolone, which is much, much weaker than dihydrotestosterone, they can suffer the same, we used to call it decadic, right? Mm-hmm. Issues because of that association. So with finasteride syndrome, I've always said, well, you pull the finasteride from the patient's regimen, and within 2 to 3 weeks, the dihydrotestosterone starts being formed again, and the erectile dysfunction resolves, and everything's hunky-dory. The problem is when it's given to someone in their youth, and I argue based upon what we learned in school, pretty much hardwired or soft-wired or fully developed by age 26. Mm-hmm. If you give it to someone when they're 19 or 16 or 20, let's say, you run the risk of disrupting that formation of the HPA axis. And then, again, rarely it happens, but it can happen. And by the way, this is all theory, but it makes sense. And I've seen 2 people in my practice that were given finasteride by physicians when they were, I argue, much too young. I don't even know why you were considering worrying about getting bald when you're 17 years old. But, you think of your family tree and you see all your uncles and...
Preventative.
Yeah, by 28 they were bald. But anyway, the issue becomes this disruption in the formation of that axis, and you can see something like this. Now, I'm not saying that this gentleman who doesn't leave a name should start to worry yet. Again, but let's address it, because you might have thrown things off and it's a little early yet to punt or say, hey, it's never going to work. I don't know what the PCT was that was given by a local nutrition store, but obviously wasn't a pharmaceutical PCT.
Over-the-counter, yeah.
But to address it with tamoxifen, the Nolvadex, or I don't like Clomid so much because of the zooclomifene isomer that's in there, but enclomifene might also work well, considered both a SERM and a SARM. But again, all through the doctor's supervision, these are things that you can bring up with them. The issue here that would lead me to encourage this patient to get at it sooner rather than later is, you basically left all this behind you in July, and here you are in January and still suffering from some of these issues. So that's a little bit more concerning because, especially given the short cycle of radical 40 you're on, it should have resolved by now within, 3 months, I would argue, tops, right? Because whether you use PCT or not, PCT just smooths out the transition. It tells the body to do it a little more quickly. Mm-hmm. What I mean by that is, if your testosterone is low, your body, if it's working properly, remember that hypothalamic pituitary adrenal axis, the pituitary is going to scream at the testicles, hey, get going, man. You've got low T, and I'm only 19 years old.
Right.
58, not so much, but at 19, it's going to go, where's the juice? Where's the beef? So, PCT or not, your testicles should have gotten plenty of commands from the pituitary via luteinizing hormone to get cracking again. So this might be something where just by stimulating the testicles to produce again, either using an indirect method of enclomifene or tamoxifen to do so, or a more direct method like HCG, it might be beneficial. And just sort of what I've found in practice over the years is just sort of getting things up and running again, whatever way it takes. The body says, oh, okay, that's the way we're supposed to do it again, and does it. And I know that sounds totally unscientific, and it is. But we're interested in the results, and it might be worth, again, visiting a urologist, maybe even a primary care, but a doctor to get that in motion. But I wouldn't necessarily get depressed and give up. I realize it's hard to feel wonderful when you have low testosterone, assuming that's what's going on. Also, I have to say, January, especially given the year we've had, but January, a lot of people are affected. Assuming he's up in our hemisphere, but maybe I shouldn't. but by seasonal affective disorder. So
Right.
that could be adding or confounding, if you will, to the problem. But yeah, 19. The odds are you still got things that are working that can help repair this situation. So don't give up. Address it with a physician who knows what's going on. The fact that you put on 20 pounds in a month, it's a little suspect because that's pretty rare. So you wonder how much of that was a side effect, for example, water retention
I'm sure.
from maybe producing too much estrogen or something else going wrong within the hormones. So,
It's not pure muscle, that's for sure. Not 20.
yeah, well, look, what I could quote, some of the things that would happen from guys. Who was the bodybuilder from Tennessee? He's passed on now, but I'll think of it if I don't think of it. But, guys who had been there before.
Yeah. Oh, yeah.
And, in a month could put on 40 pounds of relatively solid meat. But a 19-year-old, to put on 19 pounds in a month is pretty, of solid muscle, lean
It's
muscle.
not all muscle. I'm sure it's
pretty rare,
muscle,
yeah.
but some water or something.
So very suspect there. But, again, don't necessarily be scared, but address it and let's get you fixed up.
Yeah, there you go. Thanks, Doc.